All right, everybody hear me? Awesome. All right, so a couple things real quick before we move into the next section, which is the hematological emergencies. I have a kind of a list of notes, and also one thing I didn't do is I forgot to hit record. So like that entire first hour and some change was not recorded for your classmates. So yeah. So I'm gonna do a quick highlighter review, which is what my plan was anyway. Just based off of some of the notes that I've got based on the different types of diabetic emergencies. And then a quick talk about the protocol and the two formularies associated with that protocol. So, all right, so DKA. So some things that are common with DKA. First of all, they could be, so this is elevated blood sugar. They could be, they're hypovolemic. So they could be as much as 10 liters, have a 10-liter deficit. They're low in potassium as well. So that could cause EKG changes. And so virtually what we're doing is the body's created a situation where it's completely starving. It cannot, the cells cannot use the glucose that's available in the blood, but they can't use it. And so the body's starving. So you have a lot of different types of metabolism that are happening and within the cell and creating a breakdown of fats, which creates lactate, which creates, or the anaerobic metabolism. The breakdown of the lipids cause the ketosis, which is the DKA part of that, the diabetic ketoacidosis. And these patients are typically younger and they're type 1 diabetics. So hypotension, they're acidotic, they'll maybe have Kussmaul respirations, which we talked about, which is helping as another buffer system, respiratory system as a buffer to help get rid of that acid. Elevated blood sugar, there is a prostaglandins release, which is associated with the abdominal pain, inflammation, which creates a bigger vascular system because there's the inflammation, nausea and vomiting, and mortality in these patients is 1 in 20. So if a patient has been diagnosed with DKA, 1 in 20 of them will die. So it's a critical critical patient type. So it's treatment for these patients: fluid, stop insulin pumps, focused history, figure out what's going on, getting to the bottom of their condition. Oh yeah, I guess that would not be. I don't know why I've got that in that section. Sorry. So yeah, no, the insulin pumps. They will have insulin pumps, but yeah, it's probably that may be a source of the cause as an issue. So is an issue with the pump. So think about with these patients. Think about their concurrent etiologies that may be present. So the renal failure patient, the CHF patient, the COPD patient, the respiratory failure patient, like all these things can be made worse by hyperglycemia, or hyperglycemia could cause a lot of those different types of etiologies. So the HHS, so the hyperosmolar hyperglycemia state, as well as it is an elevated glucose, it causes an elevated serum osmolarity. There may be minimal or no ketone production because they're not breaking down the fats. It's often a type 2 diabetic with lots of comorbidities. So let's think about this patient. So you go on to the typical life care patient, right? And they're laying in bed. Maybe they have their baseline. Maybe they had a recent stroke or whatever they're there for, but they're not able to communicate and they're not able to ambulate. So what is the chances those people can communicate, or their desire for fluid, like, hey, I'm thirsty? So some of those patients are telling, maybe dehydrated already, which is now going to make that situation worse. So where you'll see this is in the patients who are unable to hydrate themselves. They're in a living facility where their access to to fluid is regulated by somebody else. They will be in profound dehydration. They'll be 10 liters, have a 10-liter deficit as well. And I've got here noted that it's always caused by something else. So it doesn't happen by itself. So there's always some other reason why it happens. Like type 1 diabetic, it could be the body, the body decided, hey, I'm not going to excrete insulin anymore. Pancreas says I'm out. But with a HHS patient, there's always something else that's caused it. And that could be anything from a sepsis, that could be poor care, it could be an infection. And the mortality rate in these patients is 1 in 3. So if we get to that state where there's that they are in HHS, there is a high mortality rate. And I will tell you that probably most of these patients we write off as septic, or not write off, because we in EMS, we're doing a better job of prioritizing sepsis. And so I shouldn't say we're writing it off as, but did the sepsis cause the HHS, or did the HHS cause the sepsis, or worsen it? So treatment, fluid replacement, 2 lines. You can do, like I said, their deficits of 10 liters. Not saying that we need to do the 10 liters ourselves. We should be doing maybe 1 or 2 liters in the first hour. Most of that will be happening in the ER and in the ICU. They need insulin, which is something we can't do, but we'll get them to the hospital where they can do that, and then treat any underlying cause. So as we see these patients, we can rule out some of those things. We'll be a lot better off. So we talked, for those who are going to watch this recorded, we talked a little bit about metformin, and I encourage you to dive into metformin. It's a very common prescribed medication that we really need to understand, especially things like its interaction with the kidneys and how it can exacerbate kidney failure, renal failure. Hypoglycemia. So the symptoms, we used an acronym of TIRED. So tachycardia, irritable, restless, excessive hunger, and diaphoresis. So hypoglycemia will, if uncorrected, will lead to unconsciousness and ultimately brain cell death and ultimately death. The treatment is to feed them. Whether we feed them orally, if they're alert enough to follow direction, they can eat. That should be our primary choice. But or oral glucose is a good option. But if they're unconscious, then we also need to feed them, but we're just feeding them through their IV. So I recommend starting with an amp or half an amp of D50, which is 12.5 grams, and doing serial blood sugar checks until you correct it. So IM glucagon is an option as well, but do they have the liver stores? And so that should be on your radar as well. So if they're already hypoglycemic, there's a chance those liver stores may have already been exhausted. So you may not get the response with the IM injection of glucagon that you were hoping for. Frequent blood sugar checks, some complex carbs on board, that life-saving peanut butter sandwich, and then be cautious of rebound hypoglycemia. So if you have a situation where you have persistent hypoglycemia and a persistent altered level of consciousness, we should be moving on to the hospital, and it would be acceptable to infuse D5W or D10 or D25, depending on the route that you decide to go. Always determine the cause. These people they aren't just spontaneous, there's a gravity storm rolling into town. There's not a hypoglycemia storm that rolls into town that knocks these people down into hypoglycemia. There's a cause. Something happened, and it's important for us as providers to figure out what that is and reverse it, or coach and teach and mentor and help these people understand. Be a community resource for them, so that you're not going there every week to wake up Bob because he doesn't understand that he can't take his insulin and not eat. So, all right, so let's look at the protocol real quick. I got that brought up. So the protocol 12 is hypo and hyperglycemia. It covers both options. So if you have a patient whose blood sugar less than 60, you go down this route. For an advanced, you have the option of glucagon. If you don't have IV access, you have D5W, and D50 is now available to you. And D10, but max is 25 grams. So when we look at the formulary here as well, in the hyperglycemic patient, whether it's DKA or HHS, the treatment is the same, and that is lots and lots of fluid. I mean, this should be like 2 liters in the first hour type of thing. Doing bilateral IVs and getting a lot of fluid on board is ideal. Cardiac monitoring for the paramedic, and then doing all your rule outs, altered mental status, ingestion, stuff like that. But if you have a reading on your monitor or on your glucometer that's above, especially something that reads high, you need to be just planning on this. This is and with signs and symptoms of dehydration, you should just jump on this and get fluid on board. So the treat and release protocol is 12B. These are things that we should be thinking about every time we go on these patients if we're going to leave them there. And this is our opportunity to shine as a provider, as a clinician. So we should jump on those opportunities. Protocols, glucagon, or formulary, I'm sorry. Glucagon, the range is 0.5 to 1 milligram IM, 20 minutes as needed. But again, if you need it after 20 minutes, it's probably there may be a lack of stores to access. And these are the 2 protocols. But the only one you're going to be worrying about as a advanced is number 12, the hypo and hyperglycemia. So, and then the other option, or the other thing that you need to be is familiar with as an advanced is the dextrose. So we have dextrose 5% in water. This is in your protocol or in your arsenal now. So this gives you what the so a whole bag will have 12.5 grams in 250 milliliters, and you just flow it till titrate to effect. But like I said before, you have to realize that that's dextrose in water and not dextrose in normal saline. So if you're anticipating doing a bunch of fluid replacement with D5, you need to understand what it's doing with water. Their body responds much differently to water. So the D50, half an amp to an amp. I would suggest starting with a half an amp and then reevaluating using the other half if you need to. Just be familiar with these protocols and the formularies, contraindications, side effects, things like that. So. All right. Are there any questions on diabetic emergencies specifically? No? Anyone? All right. Again, I apologize. I did not record the whole first part of that slide, but that was a quick rundown. So we're going to move into hematologic emergencies. So hematology is a study of blood. The hematologic disorders refer to any disorder of the blood. So anything from a bleeding disorder to any disorder with the RBCs, red blood cells. So the functions of blood, I mean, it does a ton of different stuff. It brings all the nutrients, it moves glucose, it excretes, or it moves all the waste to the kidneys or wherever it needs to go. It regulates its defense. I mean, blood does a ton of stuff, as we all know. Just a quick review of hematology. So the components, this is again a review: plasma, red blood cells, white blood cells, platelets. These are all the different parts of the blood and what they do. So blood forming organs, most of the blood is produced in the bone marrow. The liver produces the clotting factors, and it also filters blood. The spleen filters and breaks down RBCs, because RBCs have a life. They don't live forever, so there has to be a way to get those broken down red blood cells out, and then it helps produce white blood cells. So there's different types of blood classifications, and I do believe that if I remember right on my paramedic test, there was actually more questions on blood classifications than I ever thought they would ask. So I'm not telling you that there will be on your test, because I don't know what your test is going to be, but I'm telling you, I was shocked at how many questions I had on this. It was probably 5 or 6. So if you're not that familiar with it, get some familiar. All right, here's a question. What about hyperglycemic patients with fluid retention in extremities or ones in fluid restrictions? So I would say if they're in hyperglycemia, I'm not sure who asked this question, I can't see, but it's a great question. So this goes along with what so this is going a little bit back. All right, thanks, Ryan. So this goes a little bit back to what I already talked about. Consider the comorbidities. So if you have a patient who has CHF and they've got pedal edema, they've got left-sided heart failure, right-sided heart failure, whatever heart failure you want to call it, they've got an ejection fraction of in the teens, and they are sick, that may cause the patient to be hyperglycemic for a number of different reasons. The different for a whole lot of different reasons. So in those patients, we do have to be concerned about the fluid that the body already has. But what's interesting about these patients who are in HHS especially is they're already dehydrated. So can you have pedal edema and be dehydrated? The answer is yes. Do you have to be judicious and careful in your ongoing assessment? Be very, very thorough? Absolutely. To dump, 8 liters of fluid on a patient who has CHF, you do run that risk. But these patients are going to be dehydrated, and they're going to be hypovolemic because of it. So if they have a low blood pressure and their CHF, they have pedal edema, their respiratory distress, and you also find them to be high, then it's one of those things where you have to kind of weigh out which one's going to be more beneficial to treat. Keep in mind, your treatment for HHS is fluid, but if they're having breathing difficulty because their CHF is exacerbating as well, then that's probably the more priority for you to treat. So, CPAP, and even on a CHF patient, as long as we're judicious with the fluid and mindful of what the fluid's doing and why this patient has the pedal edema and things like that. Oftentimes CHF is accompanied with hypertension, but in this case they'll be dehydrated. So it's one of those chicken or the egg thing, but if they truly do have HHS, they are dehydrated and will need the fluid. Is it going to be 100% up to us to make sure they get all 10 liters? No, that's not up to us. But to start fluid, listening to lung sounds, making sure they're clear, correcting the respiratory issue in conjunction with, I think you're well on your way. Does that answer your question? Sweet. Thanks for the question. All right, so blood classifications, there's you can read through all this stuff, and then we all know that there is such thing as a transfusion reaction. So if patients getting transfused blood, they could have a reaction, how to treat that. We're going to talk about anaphylaxis here in the next lecture. So sickle cell disease. So some cool, interesting things about sickle cell disease. So it's commonly, I don't know why they say it's most common inherited, because my understanding is it's only inherited. Like there's no other way. It's not contagious. You don't get it. You can't just automatically adopt it. It's only comes through hereditary, but maybe there is something out there that causes it other than hereditary. But it's a blood disorder. So, and I think we probably understand it at basic level. Hopefully I heard, a couple weeks ago or a couple of classes ago, we talked about it briefly, about sickle cell. The reason why they call it sickle cell disease is because instead of the nice, smooth, plate-shaped RBC or whatever it is, I think there's a picture of it. Yeah, here. So a normal red blood cell is nice and round and smooth and has a lot of surface area. Well, sickle cell disease, they call it sickle cells because they look like sickles, like you would harvest a field of grain with. Like you chop through it, and the surface area is much smaller. There's not as much, it doesn't have the properties to carry as much, good or bad stuff. And they have a greater tendency to cling together. So that's some of the symptoms you'll have. So the other thing that is also that I don't think this PowerPoint slide talks about, and this is just, maybe this is this is how I learned it and why this was important to me, is first of all, it's more common in African Americans or people of African descent, not just African Americans, because there's people from African descent that are all over the world. But what's interesting is that this is one of the best examples of natural selection that we have on the planet, because sickle cell disease is immune to malaria. If you have sickle cell disease, you cannot get infected with malaria. So there are more people in Africa that have sick or from Africa of African descent that have sickle cell disease because they are also less likely to have malaria when malaria is prevalent in Africa. Kind of a cool. So this is, years and, generations and generations and generations and generations. So there's more people that survived that had sickle cell disease because they didn't get infected with malaria, so they reproduced, blah, 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 yada, yada, yada. Now, it's kind of an interesting little tidbit about sickle cell disease. So the couple of different things about sickle cell disease that we may run into in EMS is, one, they might be having an acute crisis, or vaso-occlusive crisis. These other things, acute chest syndrome and ablastic crisis, those are things I've never even heard of, and wouldn't know exactly what the treatment is. And that's what's interesting about this type of disease. There's really not a whole lot of treatment we're going to do, so we're not going to spend a lot of time on it. But the idea is that what happens is the blood that doesn't coagulate because it's not a clot, but they kind of congregate and hook together, and it creates vaso-occlusive problems. And whether that's in the spleen, or whether that's in the liver, or wherever that's in the extremities or in the chest, wherever that may be, that can occur at any time. So, all right. So in acute crisis, patients may have a substantial pain resulting from congested vessels. So they may be dehydrated, which might precipitate because less, fluid in the blood vessels means that there's more red blood cells, which means more likelihood that they're going to congregate and get hooked together. And the patients with chronic sickle cell attacks are vulnerable to severe life-threatening complications. The other thing to know about sickle cell disease is that these people are usually very well educated on their own disease. And not often are you going to be the first person to ever run across a crisis. You may get called for a crisis, but you're going to go in there and hopefully that's one of your questions. Has this happened to you before? And they'll be like, yeah, I know what this is. It feels the same. It acts the same. I know I'm susceptible to it. I know what I did to cause it or what happened that caused it potentially. And I just need to get to the hospital now. And that's our job. Get them to the hospital where they can be managed. So these are all the different complications that can come with it. So these patients might have a number of other comorbidities that we may or may not be familiar with, gallstones, all sorts of different things that affects as well. So anemia is another another blood complication that we can come across. So anemia is just defined as a reduced hemoglobin or reduced red blood cells in the blood. So most commonly you'll find this with an iron deficiency, and many people will take an iron supplement, or they have a regular routine to go in and get an iron infusion. I went to class with a female that was about my age, who every Friday she'd have to go in and get an iron infusion, and because otherwise she'd be anemic, and if she ever missed one, it would be a miserable experience for her. So again, many of these people are going to know, but people can become acutely anemic without knowing why, and or without having a history of. So it could be an autoimmune disorder, and oftentimes patients with anemia will just feel general malaise. They'll feel lethargy. They'll be extra weak, maybe syncopal, things like that. So because they just have less red blood cells helping move stuff around in their body. Chest pain, I have never seen that associated chest pain with anemia, but apparently it's worth noting. And leukopenia and thrombocytopenia are other conditions that are common with anemia. Clotting disorders, again, these are things that we probably won't run across, and there's not really much we can do. If somebody has a clotting disorder, we're going to treat them. We may be told, like with our history we get from family or from the patient, yeah, I have a clotting disorder, that's why I'm bleeding. But this would be no different than many of our patients who take a blood thinner we're dealing in a trauma. We understand that it may take a little more, fluid resuscitation to prevent hypovolemia, or it might be harder to control the bleeding, things like that. But there's not a ton of things. But just understand that clotting disorders can affect, it affects a ton of stuff going on in the blood, so that it doesn't clot, obviously. So the other one, though, is it's not just a reduced ability to clot, but you can have a blood clotting disorder that causes blood to clot, and those patients will usually be managed with medication, blood thinners, and things like that. So, but that could be the other thing. If you go on a patient and they are have stroke-like symptoms, that might be some of their history, is that they have a thrombophilia, and they take something to combat, to reverse that, and maybe they didn't take it, so now they have a blood clot that's caused a stroke. So the risk factors. So there's heightened issues when person has this, if they're in surgery. Usually their mobility is impaired, CHF, all these things. So usually in older people, overweight, obesity, smoking, oral contraceptives, all these things. A lot of things that we already associate with clots already. So, but if they have this condition, it can make that just that much worse. Hemophilia. So this is the opposite, where clotting doesn't occur. So lots of extra bleeding, and a couple different types. I'd be familiar with these. We're not going to talk about them at length, but yeah, could be the source of like an intracranial bleed, like a spontaneous one even. So. And many times these patients will get transfusions. All right, disseminated intravascular coagulation. So may result in any number of life-threatening conditions. Free thrombin and fibrin deposits in the blood increase. Platelets begin to aggregate. Uncontrolled hemorrhage may result in severe reduction in clotting factors. So this isn't something that you're going to see the DIC that often. There might, these patients are around, there's plenty of people who have this disorder, but not something that we're going to see or treat acutely. If they're bleeding, we know to stop the blood. If they're hypovolemic, we know to increase blood volume. If they're, they have a clot, we know to treat for a stroke. So it's important to know some of the background and why these things might be happening, but at the same time, it's not going to change a lot of our treatment plans. So assessment of these patients, so size up the scene, precautions. Many of these blood disorders are not going to be communicable, but we should still be taking all the precautions as we would with every patient. So primary survey, history is a big part of these. Most of these people will know what kind of history they have. Even though a person has a history of sickle cell disease, it may not be the cause of the current problem. So, they said earlier in the slides that patient would have angina type chest pain. If you find out they have sickle cell disease, don't just like, well, it must be sickle cell, what's up? And then walk out, treat them for their chest pain, take it seriously, because it may not be the cause. Goes without saying. SpO2, 94 or above, high flow oxygen, monitor, airway, increased heart rate, represents compensatory mechanism. I think these are all common things that we should know. Rapid transport. Like I said, history is super important in these patients. Many of them, especially the sickle cell patients, they will know what's going on. They will be able to tell you, yeah, this is, or no, this isn't. Trust them, or a family member may know. So, like I said, yeah, ask them. Have you had this before? When was the last time you had one? How did you fix it? Have you had any other illness? Secondary assessments. Is that better? Yeah, I'm getting low batteries. I don't know if these are good batteries or bad ones, but I'm guessing bad. Yeah, except we have one more chapter real quick. We have one more chapter. I'm supposed to do 21 and 22. But, all right, hear me? Awesome. All right. So that's all of that chapter. Any questions on diabetic emergencies or hematologic emergencies? Anything? Anyone? All right, so we're going to go through this chapter as well. This is immunological emergencies. This is a much smaller lecture. So, and the highlight is anaphylaxis, which I think is super important that we talk about. So we're going to try and get through this pretty quick. We are at 11, so should be done in here about 30 minutes, or if not sooner, so depending on questions. So immunology, recognition and management of shock and difficulty breathing related to anaphylactic reactions. So that's virtually the big thing that we need to talk about today. And understanding the difference between allergic reaction and anaphylactic reaction. Many of you can already identify that, and that's fine, and that's great. I mean, that's super critical piece of information that we have to have and figure out on these patients. But so 1,500 Americans die annually of acute allergic reactions. Allergy-related emergencies involve airway obstruction or cardiovascular collapse, or both. Usually, if it results in death, that has both aspects to it. So we need to, as an EMS provider, we have to distinguish the difference between the body's usual response to an allergen and an allergic reaction. So anatomy review. So we have, I would just encourage you to go back and look through this stuff in your A&P or Pathophys. Your body protection systems, you have a cellular immunity and humoral immunity. The 5 general categories are of allergens: insect bites, stings, medications, plants, foods, and chemicals. These are all different types of things that will affect or cause some sort of a immune system reaction, whether it's allergic or an anaphylactic. So the physiology, a little bit behind it. So the first encounter begins with the primary response. So, and then the body develops sensitivity through the primary response. So this is like the reason behind vaccines, right? So a vaccine gives you a small amount of this is the very rudimentary, don't quote me on all this, but a very rudimentary understanding of a vaccine. They give you a small amount of the antigen in through a vaccine, and then your body understands that that's bad, attacks it, kills it, and then it understands that in the future, if it sees it again, it's going to attack it again. So then your body doesn't have to worry about fighting it off. So, but this can happen with a number of other things too. So like if you work in a chemical plant, or if you come in contact with a chemical that you haven't been in contact with before, you may have an initial allergic reaction. Well, now your body knows, hey, that's bad. Next time you come into it, they said, oh crap, and they have like this huge systemic response, and it causes you to have an anaphylactic reaction, even though you contacted that chemical once before. Now it knows, oh man, it's bad. We got to do everything we can. So the body places specific antibodies, basophils, mast cells. These are all things that you should know at some degree. I'll be honest with you, I don't know them that well, but I do know that those are the catalysts for these reactions. When chemical mediators cause systemic effects, they cause anaphylactic reactions. So we'll talk mostly about the anaphylactic reactions today. So this is a fun little diagram of all the stuff we just talked about, and then causing the systemic reaction. So an antigen comes in, whether it's a bee sting, and the antibodies are on the cell. It can cause, the systemic reaction, whether it's in the lungs with the bronchospasm, vasoconstriction, the heart, a decreased output, and decreased coronary flow, blood vessels, vasodilation, and leakiness, and skin, urticaria, edema, pruritus. So all those things can be caused by one little sting from a bee. So like just talking about the vaccine. So an acquired immunity is a vaccine. A natural immunity is something that happens, you just happen to come across. Most of us have a natural immunity to peanut butter. We've had peanut butter early in our life. It doesn't harm us. We have an immunity to it, but we know that peanuts can be lethal to certain people who weren't able to acquire that natural immunity. Pathophys, immune system becomes hypersensitive to one or more substances during abnormal reactions, and an allergic reaction is the reaction by the body's immune system. So, and that only occurs after you've already been exposed once. So, allergic reactions versus anaphylaxis. So the big take home here is that an allergic reaction is a mild or localized reaction. It can have a systemic reaction, but most of the time it's going to be limited to, some sort of one part of the body or one part, and it's usually mild. So, can you have an allergic reaction that causes bronchial constriction? Yes, absolutely. That's why people take, allergy shots, or they're allergic to hay fever or whatever, or hay, or whatever, or some sort of pollen. Those are all, that can cause, but that's not an anaphylactic. So the anaphylaxis is first of all, it occurs differently at the cellular level with the IgE antibodies, but an anaphylactic reaction is systemic in both respiratory and circulatory. So that's the big difference in an anaphylaxis reaction, and it's super fast. Well, I guess we'll talk about that too. In some instances, it can be a little bit delayed. So mast cells recognize the invading substance and release chemical mediators, which is the histamine, and histamine causes blood vessels in the local area to dilate. So that will cause a swelling. So you get stung right here on your hand, you're going to get swelling. That's the histamine release right there. Leukotrienes are more powerful than histamines, and they can cause additional dilation and leaking. So you could have swelling and leaking vessels all in a local area, but at the systemic level, in a like an anaphylactic reaction, you can have that across the entire body. So you have swelling in several areas. You have, profound urticaria or hives across the whole body, things like that are completely distant from the site of insult. White blood cells help engulf and destroy the invading substance, and platelets begin to collect and clump together. So that's where all the swelling and stuff comes from. So, like we said, anaphylaxis, the initial effect may be seen from release of the histamines, with secondary effects following a few hours later. So just because they had, an insult, the bee stings them now, we show up, looks like it's an allergic reaction, doesn't mean that it's not going to progress into anaphylaxis at some point. But usually, the way that I've seen it is that most times the anaphylactic reaction is initially pretty easily and readily identified early in the insult. So, all right, so the clinical symptoms of anaphylaxis. So the skin symptoms are often the first indication. So you'll see swelling at the site. You may even see, you'll see hives or urticaria pop up almost immediately. We could be there within minutes, or it happened right in front of us, and you can start seeing the systemic urticaria. So you'll see that on the torso, around the neck, on the arms, but often it'll be on the torso and the upper chest. That's a really common place to see that. So the angioedema may contribute to airway compromise. So angioedema is swelling of the airway, the upper airway. So you might see swelling of the tongue. They might be able to not, you might say, oh, I feel my tongue swelling. Feel some swelling of the hands and feet. Respiratory symptoms, most common, so like I can't breathe, I'm having a hard time breathing, it's getting worse, it's getting worse. And then cardiovascular symptoms are serious complications. So when the patient has all those other symptoms, they can't breathe, they have urticaria, they have localized swelling, they have systemic swelling, and they tell you they can't breathe, and then you check a blood pressure and their blood pressure's 70 systolic, you have a problem on your hands, and it has to be dealt with immediately, because that is a true anaphylactic response, and it is fatal and very critical at that point. And early intervention is the key. So blood volume, and the reason why we have the hypovolemia, or the hypotension, I should say hypovolemia, the hypotension is because we have a histamine release that's systemic. It's now causing dilation of the vessels, and it also causes permeation of the vessels as well. So now you're going to start third spacing. The fluid's going to start moving into outside of the vasculature. There might be some gastrointestinal symptoms, belly pain, maybe diarrhea, vomiting, nausea, things like that. And then central nervous system symptoms, so headache, dizziness, confusion, anxiety, the sense of impending doom. If they tell you, this is bad, I'm going to die, listen to them. They know what they're talking about. They feel it. They've maybe had it before. They understand. So you got to listen to them. Pat them on the head and like, no, you'll be fine, is not the best treatment there. That should be like, okay, crap, we need to go to work. So patient assessment, identifying intervention within seconds is crucial. Like I said, this is something, as soon as we can identify it as anaphylaxis or allergic reaction, we need to differentiate the two, because while some of the treatments are the same, anaphylaxis is a true critical emergent, has to be dealt with now type of response from us. So the response to the antigens may occur in a multi-step manner, can be acute or delayed. Most of the time, if it's anaphylaxis, it's going to be acute. Prolonged persistent reactions, anaphylaxis symptoms can continue over time, 5 to 72 hours. That's why a lot of these patients get admitted. Maybe they've even had to be intubated to keep their airway open, and now they're going to be monitored in the ICU for several days. In a biphasic response, patient experiences an initial reaction and then appears to recover and then experiences a recurrence of symptoms. I have yet to see this in EMS, but there have been plenty of scenarios where the patient will tell me, oh, this has happened before, and usually I get better, but sometimes I've gotten worse. And in those scenarios, I'm encouraging transport so I can monitor them, give them an epi or Benadryl, whatever treatment I need to give them, monitor them mostly and ongoing reassessments, and then get them to the hospital so that they can get definitive treatment if it happens, if they have that rebound, or that biphasic response is how they call it, but if they have that rebound episode. And sometimes they refuse and like, no, I got it. I've got my EpiPen, I understand, I'm going to go. Well, go. You have to go. Okay. So just make sure that's clear. Scene size up. So the big thing on scene size up. So if you have an anaphylactic reaction, or if you get called for an allergic reaction or allergies or whatever the dispatch code is, and you walk in, or in dispatch information, or you approach the scene or whatever, and you have people with multiple symptoms, I mean, your hairs on the back of your neck should be standing up, and you're like, oh, I'm not going in there. Like, somehow we got to do something to make sure the scene is safe. So don't go into a scene where more than one person is experiencing the same type of symptoms. That's a hazmat scenario, hazmat scene. You got to protect you and your partners above and beyond everything else. So got to determine the mechanism of injury. Most of these people are going to be insect stings or in contact with a chemical that they're not familiar with or something like that. Identify that stuff as soon as you can. And then just be on high alert, especially when you're in that scene, so that you don't get infected as well. So the severity of the problem will be indicated by the patient's presentation. I agree and disagree. So the patient's presentation could be, I've had some people that were very close to anaphylaxis, or, and they were very calm because they knew what was going on. So they didn't have that wide-eyed, oh crap feeling. But they knew what was happening, knew what needed to be done. They called 911 and we got there and we were able to reverse everything pretty quickly. But I've been on scenarios too where they're like panicked. They have these big, huge eyeballs just staring at you like help, 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 help. And so The severity of the problem may not always be indicated, so don't let your guard down on that one either. Your assessment, your full set of vitals, and all that stuff is going to help you kind of guide your treatment in these patients. So respiratory symptoms should be swiftly assessed. So if I have a patient who is telling me they have, they got stung by a bee, a couple things I want to know really quickly. I want to know, first of all, I'm going to ask them, are you having difficulty? No. Then trachea. I want to hear whether anything that resembles wheezing or especially stridor in the trachea. You're going to have stridor in that airway. And then I'm going to listen. I'm going to listen to tracheal air, and I'm going to listen to upper respiratory. If I hear anything that closely resembles wheezing, then I know I've got a problem that I need to address. The other thing that does is it sets a baseline. As soon as I see him, within a minute, I'm doing that. And if I reassess in 3 minutes and now I hear wheezing and now I hear stridor, then I know I've got a problem, right? And it's kind of sets and then I'm constantly reassessing those things. So position these patients in a position of comfort. Most of them will be in a tripod position or something like that. Don't force them to lay down. Just let them sit. They know how to, what's going to be the best for them to breathe. Unresponsive patients, we got to get ventilations using a bag mask, a BVM. And if we are to the point where they're unconscious, then we'll probably have a respiratory compromise or cardiovascular compromise with the hypotension, with the systemic response. And we have a lot of work to do in really short order. Begin basic life support measures if patient is unresponsive or pulseless. And then we need to, in that scenario, if we're doing CPR, we have to rule out the H's and T's as quick as possible. In this scenario, we're reversing hypotension and hypovolemia. And the only way we're going to be able to do that is, we're going to be reversing hypoxia. Did I say hypoxia? Hypoxia and hypovolemia. So we have to get oxygen, BVM, intubation, early intubation on these patients. I-gels may not be the best option for these people because their airway still could clamp without an I-gel or with an I-gel. So getting a paramedic come in and making sure a paramedic is there to manage that airway is probably best. Administer the oxygen and then get large bore RVs going and fill these people full of fluid. So treatment for shock. Those look like basic interventions for shock. Oxygen, supine, and keep them warm. Continue assessment at scene if the patient is calm and does not exhibit any symptoms. So I think that's reasonable. If they have an allergic reaction and it's it's not systemic, it's localized, that's something that can be managed on scene. I wouldn't ever discount it and just say, because there's always that chance that they could have a rebound or a biphasic, I think is what they called it, biphasic response. But many of our allergic reactions are going to be acute, but not systemic, not critical. So investigate the chief complaint, identify the associated signs and symptoms, get a sample history, physical exam, vital signs, cardiac monitoring, reassess on scene or en route to the hospital several times. Like I said, I'm constantly evaluating their airway, their lung sounds, and their blood pressures in these anaphylaxis patients. Special attention given to any signs of airway compromise, and that's, like I said, intubation, that's supporting supplemental oxygen, things like that. But mostly, if you aren't able to reverse the airway complications with medications, then they need to be intubated early because that swelling is going to happen fast. Check the effect of epi administration. So we give epi in these patients in the acute setting, and the reason why is, Warren, do you have any idea? Perfect. So Warren says that we give epi so that we can constrict the vessels and dilate the bronchial tree. So, and that's exactly right. Those are both the exact reasons why we do that. It doesn't slow down the histamine release. It doesn't stop any of that type of stuff, as far as I know. But those are the two things that we do, and that's why early epi administration. That's why the EpiPen is so effective, and why people have EpiPens. So, but we have to continually reassess. Many of these patients, especially if they're going into anaphylaxis, will need multi-doses, several doses. So, contact medical control, I guess, if something's outside of your purview. Some allergic reactions, you may use standing orders, which we have standing orders for epi, and documentation should include detailed signs, symptoms. Yeah, ensure to record patient's response to the treatment. All that stuff makes sense. So I guess to kind of sum up, I don't know how many more slides there are, but it's absolutely essential for us as providers to differentiate an allergic reaction from anaphylaxis. Does the treatment change? Not really. In an allergic reaction, you can still give epi. You're still maybe having to manage the patient for airway compromise, things like that. But an anaphylactic reaction is more life-threatening, and it's going to have both the airway and the circulatory compromise. So you have to do multiple things, manage multiple things in a short period of time, and it's super rapid and very lethal. So, all right. So people with allergic reactions separated into two groups for treatment purposes. The first group is people who have an allergic reaction but no signs of anaphylaxis, and the second group includes patients with anaphylaxis. So I just call that an allergic reaction and anaphylaxis. That's how I separate those. So early administration of epi is a priority. IM route, patient shows evidence of airway or respiratory compromise or hypotension, and administration in the thigh is preferred. Most times I've given it in the deltoid, but it says here that the thigh is preferred. This says the epi can rapidly reverse the histamine-related effects of anaphylaxis. So it doesn't affect the histamine, but it affects the histamine-related effects, if that makes sense. So it reverses the bronchial constriction, it reverses the vasodilation. Side effects of epi are worth, are they worth the trade-off in these life-threatening situations? And I would say yes. And the amount of epi that we're going to give, you're probably not going to cause a heart attack. You may have some chest pain. You might have some of these complaints of nausea. I've given it to somebody one time before and they vomited, but those are all acceptable symptom or side effects based on the reversing of symptoms that I've had. So. Insect stings, so the big thing with insect stings is find where they were stung and make sure there's the insect or the stinger, I guess is what we call it, is no longer in place. You can remove that with like a card or a piece of something rigid that you can remove it with. I wouldn't just go in with it with bare hands, but you could, but we need to inspect that site and get the stinger out. Some ants, fire ants, I don't think we have fire ants around here, but they can be a source of an allergic reaction as well. Multiple sites or multiple bites can be done by the same ant. Signs and symptoms of insect sting. So you're going to have some localized pain, swelling, heat, and that's called a maybe itching and a wheal. So WHEAL. So I don't know if that's super important for you to know, but applying ice at that site is going to be helpful. Reduce the swelling, reduce some pain. Remove the stinger by scraping the edge with scraping the skin with the edge of a sharp, stiff object like a card. So, be alert for airway swelling, other signs of anaphylaxis. That's what I said. Get your stethoscope out and listen to those lung sounds. Listen to tracheal sounds. Constantly reassessing, asking the patient how they feel. Have them open their mouth, see if they're swelling in their mouth. And regular, rapid cycling of the blood pressure, getting blood pressures over and over and over again. So patient in the supine position, oxygen, vital signs, provide additional support as needed. Educate the patient. This is another aspect of it, especially if we're leaving the patient after they've had an allergic reaction that's not systemic. Let them know that they need, that they should be doing some things, getting an EpiPen prescribed to them, bracelets, things like that. So, and help them understand why they're having an initial insult and why, and what to look forward in that rebound insult. Like in 3 hours, you may be starting to have symptoms again, and that's normal for the type of reaction you're having, but that's something to be noted, and you need to understand that's a call us back, that's a get to the ER type of event. So, all right, any questions on any of that? Sorry, that last one was pretty painful, just getting through all the slides, but I apologize for those that aren't online, but are have to watch it recorded, that we missed portions of that first lecture. But if you have any questions, feel free to call me, email me. Happy to go over some of the stuff if you need. Thank you, everybody. If you don't have any questions, I think we'll just go ahead and wrap it up.